Hi friends, in this video I shall outline the thinking process and strategies of how to manage a posterior capsular rent with vitreous in the anterior chamber that occurs during the epinucleus stage. This was a small pupil case. The initial steps of the procedure went out smoothly. It was a grade 3 nucleosclerotic cataract and I was able to successfully chop and remove all the nucleus fragments in this case. The toughest part of managing a small pupil phacoemulsification is in the nucleus management, or so we would think. But in this case I had a different problem that occurred later on in the procedure. Initial steps of phacoemulsification going on smoothly. So let's just cut to the chase, and the nucleus was removed. It was at this stage that I realized that there was a very thick epinucleus shell that was left behind, and with a small pupil this was proving to be a little difficult to remove. However, using very high vacuum and with the coaxial IA, I am managing to chip away at this epinucleus shell till at one point I make this cardinal mistake of turning the aspiration port of the coaxial IA posteriorly towards the posterior capsule. Now this is something that you should never do, because with such high vacuum it's so easy to suck up the posterior capsule, and as expected there was a small posterior capsular rent. Don't pull out the phaco probe. You have to remain in foot pedal position 1. Keep the irrigation going and then inject a little amount of viscoelastic from the side. As the viscoelastic fills the chamber, the foot pedal position is brought to 0 and then you come out. The next step is damage control, and you have to assess the situation. You can let your blood pressure and your pulse rate come back to normal at this stage. The options are, we can either go back with the phaco probe or try to remove with coaxial IA or bimanual IA. These are very bad options because the irrigation will hydrate the vitreous, the rent will dramatically increase. It may not be possible to aspirate because vitreous is admixed with the epinucleus, and you may lose the epinucleus into the vitreous. Now dry aspiration with a Simcoe cannula is probably the second best option, but during the aspiration the chamber may collapse and this may pull further vitreous into the anterior chamber and it may be difficult to aspirate. The best option I thought in this case was to do a visco expression of the epinucleus, because this will not hydrate the vitreous, it will keep the AC maintained and it will also tampen out the vitreous. A little amount of viscoelastic that escapes into the mid-vitreous can always be removed with the vitrectomy cutter later on. So this is what I am trying to do, trying to visco float out this epinucleus shell. Gently injecting viscoelastic, lifting this epinucleus and then giving mild pressure at the corneal lip by depressing it causes about a large chunk to come out, and the posterior capsular rent, which is small, has not increased during this maneuver at all. Do not over insufflate. We want to maintain the volume of the anterior chamber. We don't want to over insufflate, which will push the methylcellulose into the vitreous. And then now I am using just mechanical separation in order to tease out the remaining part of the epinucleus from the subincisional area. I've managed to get out about 80% of the epinucleus shell, which was a very great relief for me at this stage, and I have managed to achieve this without significantly increasing the size of the posterior capsular rent. The remaining bits of epinucleus and cortex I'm trying to aspirate using a Simcoe cannula, but I'm not able to get at this cortex. Now this is simply because the vitreous is admixed with the cortex. The opening in the posterior capsule is also limited. At this point you have to go in with the cutter. Now the chamber is filled with viscoelastic at this point, so just trying to put in triamcin alone, you won't be able to get a good stain of the vitreous. So initially do the vitrectomy. Go in with the vitrectomy in the cut IA mode. Now I'm using a 23 gauge cutter. You see that as soon as I went in with the infusion and the cutter, the posterior capsular rent actually became a little larger. This is alright, because they say you cannot make an omelette without breaking eggs. And during vitrectomy you can expect the posterior capsular rent to enlarge, but you are going to get rid of the bulk of the midcoat vitreous by a vitrectomy. When you're using a 23 gauge cutter, you need to use a high cut rate. I'm using 1100 cuts per minute. Also, you have to use a vacuum of 250. When you're using a 20 gauge cutter, this cut rate may be around 700 to 800 with a vacuum of 150. To cut vitreous, use the cut IA mode. Now once you have cleared the vitreous, then you can switch to the IA cut mode in order to aspirate the cortex or the epinucleus. What I'm basically trying to do is remove most of the anterior vitreous. Now once the anterior chamber is filled with balancol solution, you can now inject the triamcinolone, which is diluted 1:3. After injecting the triamcinolone, I realized that the only vitreous that is present in the anterior chamber is a little bit of vitreous coming from the subincisional area. It is wrapping itself around the pupil and coming out of the main incision. In such cases, having performed the vitrectomy, you can now use scissors in order to trim this wick or strand of vitreous that is coming out through the main incision. And this is sometimes not a bad idea. You should not do a manual vitrectomy using scissors, but having done an automated vitrectomy, the wick or the strands of vitreous astride the pupil can be cut with scissors. Then examine the completeness of the capsulorhexis, and I'm going to inject a 3-piece IOL at this stage because most of the cortex is removed and a good adequate vitrectomy has been performed. You see, I am tilting and bringing the haptic into the anterior chamber first. If you try to inject it directly into the sulcus, there's a chance that the IOL will tilt and the haptic will sink into the posterior capsular opening. The lens will then stand vertically. So always I think it is better to inject the haptic into the anterior chamber. And now I flex the haptic and put it into the sulcus, or so I believe. I think that it could be in the sulcus, the leading haptic. Now the trailing haptic, with the help of a wire rod, I rotate it into place. There is a little resistance to the rotation, and I think that the leading haptic has got stuck or slipped behind the rhexis edge. Therefore, I take a Sinskey hook, I invert it and then get hold of the haptic-optic junction. I rotate and slightly pull it up anteriorly to encourage the intraocular lens to slip into the sulcus. So I tap on the lens gently and see that the lens is pretty stable in the sulcus. After which, I try to make the pupil round by gently sweeping on the surface of the iris and trimming with scissors. And finally, the viscoelastic needs to be removed. I use a Simcoe cannula to remove this, and any imperfections of the pupil is completed using a scissors, and a nice round pupil results at the end of the surgery. Now this patient went on to do well, and this was a picture that was taken on the 5th postoperative day. So visual acuity was 6/6 with minus 0.5 cylinder at 60 degrees. However, there was a little peaking of pupil at 11 o'clock. In spite of my best efforts, there was a strand of vitreous that was coming out from this portion and getting stuck to the incision. Now my plan is to go and do a Nd:YAG laser vitriolysis, but for that I'm going to wait for at least 3 weeks to subside before I attempt it, because then the vitreous will get organized. Thank you for your attention.